you are telling me, then you are saying this because you will join and leave. Mervin, you will leave in no time.
Oh, I'll leave today.
So don't answer my question, please.
Yes, please. I'll answer again.
So where I am, I want to know where I got to.
We did the description and then we got to the source.
The source. So for the source, we said we have what? So the source or the origin, we said we have what?
The sinus.
The sinus. So when you say sinus, what does it mean? Hurry up, hurry up.
The SA node is affected.
So the problem of that arrhythmia is coming from what? The SA node. It's not the SA node is affected. The problem of that particular arrhythmia is coming from where? So the origin of that arrhythmia is coming from where? The sinus, sinoatrial node. So one is coming from sinoatrial node. We say is what? We describe it as sinus. Sinus. Okay. Continue.
And then we have the nodal.
So when you say nodal, what does it mean? When you say nodal, what does it mean? When you say nodal?
The problem of the arrhythmia is coming from the AV node.
So it's coming from the AV node. When you talk about nodal, any other? Mm-hmm.
Then we have the supraventricular.
So when you talk about supraventricular, what does it mean?
Above the ventricle.
I can't hear you.
Ventricular. It comes from above the ventricles. So it could be nodal, it could be atrial, it could also be from the sinus.
Okay. Okay. Any other? Any other?
The ventricular one.
So the ventricular. So you could have sinus, you could have atrial, you could have nodal, and you could have ventricular. So you could have ventricular tachycardia. It means that the tachycardia is as a result of a problem coming from the ventricle. When you talk about atrial, then the source of the arrhythmia is coming from the atria. When you talk about sinus, the source of the problem or the arrhythmia is coming from the sinoatrial node. So you could have sinus bradycardia, you could have sinus tachycardia, you could have sick sinus syndrome. The moment we're hearing the sick sinus syndrome, then the problem of that syndrome is coming from sinoatrial node. So that is the source. The last one we call something re-entrant. Re-entrant. So we have this to be the heart. Can you see from the board?
Yes, please.
You can see.
Yeah.
So we have this. So this is sinuatral node. This is sinuatral node. This is the AV node. This is the bundle of its. And this is the Purkinje's fibers. So I'm expecting impulses to travel from here to here. And it will go through the bundle of its. When it goes through the bundle of its, then it will branch to this side and branch to this side. So this is Purkinje's fibers. And the fibers will ensure that we have impulses getting into every remotest part of the ventricles. Impulses will get into those cells and go and cause stimulation or contraction. So that is that. But when you talk about re-entrant simply means that now we expect this pathway to occur. When you're expecting this pathway to occur, something could happen. Something could happen. Then this pathway will now be turning like this. Now there could be a block here. So these impulses will now be forming like a circuit. Instead of going through this pathway, it gets here and go back and form something like a circuit. It could also form like this. This is re-entrant. So we have sinuatral node here, AV node here. So it could also form like this. This is the heart. It could also form like this. So when you have such a situation occurring, then instead of the flow being like this, flow of impulses being like this, and it's forming like this, a circuit. When you form something like a circuit or a loop, then we term this as re-entrant. Re-entrant. So when the impulses tend to form a circuit or a loop, we call it re-entrant. So this is re-entrant. And when re-entrant form, the type of arrhythmia, that's when you have this re-entrant or loop, is called with Parkinson's White syndrome. With Parkinson's White syndrome. With Parkinson's White syndrome. So the moment you mention with Parkinson's White syndrome, it means that the impulses are forming a loop or a circuit within the myocardium, within the heart. The moment these re-entrant form, the type of arrhythmia is called with Parkinson's White syndrome. This is under the origin. So anytime you have re-entrant, or you have a circuit, or you have a loop forming, these impulses will form a loop via the accessory vessels. And This, when the loop is formed, we term it as reentrant. And that type of arrhythmia, I call it Wills-Parkinson's-White syndrome. This is that. Okay, so let's go to the pattern. The pattern. So we have done the pattern. Pattern. So we have the rates, we have the sort, and we have the pattern. So for you to describe arrhythmia, you should have these three words: the rate, the origin, and you have the pattern. The pattern should tell us, the pattern will tell us that this is coming from the sinus. This is tachycardia. This is this. This is this. Okay, so let's look at the pattern. So the pattern, you could have ectopic. Ectopic. Number one, we call it ectopic or premature contraction. I am saying this. The pattern is what we see. The pattern is what we see on that sheet. ECG, when you put the leads on the chest of a patient, the ECG, there will be drawings on these sheets that will come out from the ECG. The drawings. And that drawings, we term those drawings as pattern. So the nurses and the doctors, I don't understand why Ghana, we don't. They don't teach us, that's the pharmacists. But they teach the nurses, they teach the doctors. Outside, they teach the pharmacists. So we should know, because we should be able to read and say that this is a traffic. We should be able to read and say that this is a traffic letter. This is a topic beat from the pattern. So the pattern can give us this, can give us a topic beat. And when you talk about a topic or premature contraction or a topic, it means that the pattern will show the ectopic or premature contraction. The pattern will show. And the patient, those who know how to read, the medics and the nurses who know how to read, will tell you that when you say ectopic or premature contraction, it's the contraction listing. It's the contraction that comes from a focus. It comes from a point, either than the sinoatrial node. That's a premature beat. So assuming we have the sinoatrial node, and the normal circumstance, the sinoatrial node is supposed to initiate impulses. But if it so happened that, let's say, a myocyte in here would initiate impulses. These impulse initiation will term it as a premature contraction or beat. So if there was a focus that would cause a release of impulses, and that release of impulses, if it's not coming from the sinoatrial node, we term it as a premature beat or ectopic beat. The same as a woman has to go through a 9 months, and that is what God has made it. 9 months. Pregnancy, 9 months. So 7 months. Some of our mothers will give birth at 7 months. And for 7 months, because it's not 9 months, for that 7 months, we term it as what? A premature. Because it's not 9 months, it's before. So if you have a focus causing release of impulses, either than the sinoatrial node, other than the sinoatrial node, then we term that beat as ectopic beat. And this can be seen. The doctors can read, the nurses can read, pharmacists cannot, because we are not taught. So that is the ectopic beat. It's from a focus other than the sinoatrial node. It's not the sinoatrial node that will release it. It's a point, a focus, a point within the heart that will cause a release, and we term it as a prematured or premature contraction or ectopic beat. We have the second pattern, and we term it as fibrillation. I want you to understand these things, fibrillation, such that when I talk about atrial fibrillation, I'm going to ask you questions about this. We talk about fibrillation. So fibrillation, when you say fibrillation is a fast, chaotic rhythm coming from multiple foci. Fibrillation, listen, the moment you say fibrillation, it's a fast and chaotic rhythm coming from multiple foci. That is the meaning of fibrillation. So we say it's a fast. Now, when I say fast, it's a fast, then it's bringing in the rate. It's bringing in the rate here. I am saying that when you are describing arrhythmia, the source should come, the rate should come. And you know the source and the rate from the pattern. The pattern. So we use the pattern to describe the arrhythmia. And the pattern will tell us the rate, and the pattern will tell us the source of the arrhythmia. So we're using these three words to describe. So when I say fibrillation is a fast and it's chaotic. Chaotic. When I was explaining the chaotic, and this fast and chaotic rhythm is coming from multiple foci, So this is what we call fibrillation. So we have the heart to be like this. And this side is sinoatrial node. When you talk about fibrillation, it means that apart from this sinoatrial, other sources are also releasing impulses. So if these points are releasing impulses, then these impulses will be bombarding the AV node. So they will be bombarding the AV node. Each point will release impulses, and they will be bombarding the AV node at different times. And therefore, when these happens, the rhythm will be chaotic. And because here, all the points are coming from the atria, you will see that there's atrial fibrillation. So when you say fibrillation, it means that the things, the points in there is that the moment you talk about fibrillation, it means that we have different foci releasing impulses, and the impulses are fast. They are releasing impulses, and the impulses are fast. So they are releasing impulses at different times, at different points, and these will be bombarding the AV node. So it will be difficult for AV node to be taking all this and wait for 0.1 second. And therefore, they'll be giving us chaotic rhythm. Can you mute, please? Who is hosting it?
Doc Steve, I've muted him.
Okay. So that is fibrillation. Anytime in arrhythmia, you talk about fibrillation. I have seen a patient, one of our ward rounds, the patient had fibrillation, and there's a danger. I'll be doing only fibrillation, atrial fibrillation with you. That is the commonest thing, arrhythmia that comes. So I'll be doing only atrial fibrillation with you. We had the patient fibrillating, so we needed adenosine. They asked me which drug should we give to the patient. Adenosine works in seconds. So I recommended that they should give adenosine. But when we went to the pharmacy, I didn't get some. So I rushed to A&E. When I came back, the patient was gone. Who can tell me what could kill the patient so fast? A traffic patient. Who can tell me? Looking at what is happening, there's a chaotic rhythm coming from different foci. So different foci is producing impulses. They are fast and chaotic. So if I say it's fast, what comes into your mind? Rate is coming in here. Rate is coming. So if I say it's fast, then I'm thinking about now tachycardia. It's fast. So now rate is coming here. So fibrillation it's adding the rate. It's telling us that now it's the heart rate is what? It's fast. We are in a tachycardic phase. If you are talking about fibrillation, who can tell me what could kill the patient if a patient comes with fibrillation? Who can tell me? Who can tell me what could kill the patient if a patient comes with fibrillation?
Okay, I believe it's
Myocardial infarction.
Why infarction? Why myocardial infarction? Why infarction? Why infarction? Who can tell me what could kill the patient?
okay, I'm looking at stasis.
Why stasis?
So I believe since the rhythm is chaotic and irregular, the blood will not be able to circulate, so it will be settled at the AV node within the ventricle place.
So if it's settled, what will happen?
Blood will coagulate.
So what could kill the patient?
So that is
You're on the right path, but you're on the right path. If
PE.
yes.
what
Please, I
could
believe
kill the patient?
the blood will coagulate over there, and for that matter, the patient will tend to vomit maybe the coagulated blood.
No, don't sway. Don't sway.
Pulmonary embolism.
Good. There could be embolism, and there could be stroke. There could be embolism. We are talking about there's irregular. Now, if it's chaotic, the rhythm is chaotic, it means it's irregular. And if it's irregular, it means there will be stasis. Blood will not be pushed. There's nothing like complete relaxation, complete contraction. There's chaotic. Now, the sinoatrial node is releasing impulses. Different points here, which I'll call different foci. So these are foci releasing impulses at a faster rate. So each is releasing impulses at a faster rate. This is fibrillation. Fibrillation is releasing impulses from a different sources. We term it as multiple foci. And because this is producing impulses at different times, the rhythm will be irregular. The rhythm will be irregular. And because the rhythm is irregular, blood in the ventricles will not be able to push. There will be accumulation of blood. It could be here. It could be here. So there will be blood accumulation that will cause stasis, as Solo was saying. And stasis will lead to what? Will lead to coagulation. And when there is coagulation, this coagulation could be thrown. If the coagulation is here, it could be thrown into the lungs to form PE. If it's here, it could be pushed into the brain, it could push into the deep vein. So anything could happen. So patient coming with fibrillation, now we're talking about fibrillation, I'll talk about any patient that comes with fibrillation, you need to put the patient on anticoagulant. You need to put the patient on anticoagulant because of all these problems. So we have fibrillation, and the fibrillation, I'm saying it's a fast. It means that the heart rate will be more than 100. So it has captured the rate. If I say atrial fibrillation, if I say atrial fib, then A is capturing the origin. A is capturing the origin. And the fibrillation is capturing the pattern and the rate. Please, is it clear?
Yes, doctor.
Is it clear to everybody?
Yes, please.
Good. So we have fibrillation. I want you to understand. So the moment you talk about fibrillation is a fast and it's a chaotic rhythm coming from different points or different foci. It's a fast. So at the ward, if a patient comes of irregular, if the doctors check the pulse and they say that the pulse is irregular, then they are pointing to atrial fib. They are pointing to fibrillation. If it's irregular, they are pointing to fibrillation. Okay, so the next that we should know about the pattern, what we should know under the pattern. What we should know under the pattern is called flutter. So we have flutter. So we could have ventricular flutter. We could have ventricular fibrillation. We could have ventricular flutter. We could have atrial flutter. So flutter. When you talk about flutter is, listen, there's a difference between flutter and fibrillation. Flutter is also a fast. Flutter is a fast, regular rhythm. It's a fast, and the rhythm is regular. Note this. It's a fast, and the rhythm is regular, and it's coming from a single atopic beat. It's coming from a single atopic beat. So now you have the heart to be like this. We have some atrial node here. We have AV node here. And we have a focus somewhere here. So this will be releasing impulses. And because it's not coming from different foci or multiple foci, because it's just coming from this, the rhythm of the flutter will be regular. The rhythm will be regular. So it's a fast, regular rhythm coming from, because it's coming from a foci, single foci, returning it as it's atopic, because it's not coming from the main. It's coming from a point outside the atrial node. So you could also term it as atopic focus. Atopic focus. So flutter, it's a fast, regular rhythm coming from a single or atopic focus. Atopic focus. That is that. So whilst flutter will be given a regular rhythm because it's coming from just a focus. Atrial fibrillation will be giving you a multiple. Some will be like this, because different points will be giving you different wavelengths. So this is chaotic, but this is regular. But let me tell you this. Atrial flutter is not common. Atrial flutter is not common. Atrial fibrillation is common. Heart failure patient can easily come with atrial fibrillation. But it's difficult managing the flutter than this. Atrial fibrillation is so easy to manage. Atrial flutter difficult to manage. So coming from just a simple, it's difficult to manage. But this is easy to manage. And this is common. This is not common, but difficult to manage. So when you talk about flutter is also a fast. So I'm talking about fast. Fast is also telling me the rhythm, the rate. fast is telling me the rate. So flutter, fast, regular rhythm. Fibrillation, fast, chaotic rhythm. Flutter, fast, regular rhythm coming from a focus, atopic focus. Fibrillation, fast, chaotic, coming from multiple focus. So this is last time I was asking one of the groups about, I can also say paroxysmal under the pattern. You could have what you call paroxysmal. I can say paroxysmal atrial fibrillation. I can say paroxysmal atrial fibrillation. So we know from our learning, we know that if I say fibrillation, it's a fast chaotic rhythm coming from multiple focus as chaotic rhythm. So this is chaotic rhythm. Here is chaotic rhythm. And this is telling me atrial. This is telling me atrial. So I'm getting the source from here. Source of the fibrillation is coming from here. I'm getting this. That is the fast chaotic rhythm coming from a multiple focus. What is paroxysmal? So I can say paroxysmal. When you say paroxysmal, it simply means that where we have the problem, assuming there's a problem, there's a discharge here. We have the heart here, and there's the AV node is where the abnormal discharge is coming from. A discharge that could cause arrhythmia is like current, electricity current. There could be a spike when you join metals, when you join the cables, when you join them together, there could be spikes. There are certain spikes that you can even enjoy. When you touch on it, there will be spikes. And there's other spikes that will come. It will blast. So when we have a discharge of electrical impulses or impulses from atrial node, the impulses will come like a burst, like a blast, boom. So when impulses are coming like that, like a burst, like a bomb, then we term it as paroxysmal. So there was some abnormal impulse released here. They are saying that the impulse released from here is coming like a burst, like a bomb. When it happens like that, this will be shown on the pattern. When it's coming like that, they refer to it as what? As paroxysmal. So it comes in a burst, or it occurs in a burst. When a discharge causing arrhythmia from a point or from a focus, and it's coming at a burst, coming like a bomb, boom, we term it as paroxysmal. So you could have paroxysmal atrial flutter. You could have paroxysmal atrial fibrillation. You could have paroxysmal supraventricular tachycardia. Okay, so it left with blocking under the pattern. But I want you to do me a favor and explain this to me. I want somebody to explain this to me. Somebody to explain this to me. So we have paroxysmal supraventricular tachycardia. What does it mean? Who can explain this based upon what we have learned? Paroxysmal supraventricular tachycardia. Who can do that for me? Who can you hear me?
Attakorah. Yeah. So with this one, it's when you have impulses generated from a corpus or a cocci located at the ventricles, and the impulses come in heavy magnitudes.
You're lying as if you are sleeping and talking. Can you come again for me?
Stephanie, it's when you have impulses generated from a cocci or a corpus.
Have you eaten? Sylvia, have you eaten?
Yes, sir. Yes, sir.
Then talk. Paroxysmal supraventricular tachycardia. Go on. Go on.
It's when you have impulses that are generated from a cocci or a corpus located on the ventricles, and the impulses that are generated come in heavy magnitude, cause a fast heart rate.
I am not too happy about coming from where the ventricle. You said coming from the ventricle. Sylvia,
Yes, sir.
can you do it to work for me? Arrhythmia is difficult, I'm telling you. It's difficult.
Hello, Doc. So in PSVT, the impulses generated are coming from above the ventricles. It can be the atria, the sinus, and this impulse is fast, and it's in the form of a burst or a bomb.
Good. So supraventricular. So Sylvia, you are talking about coming from the ventricles. And Steve is right. So when you talk about supraventricular tachycardia, it means that where the source of the arrhythmia is above the ventricles. Now, the moment you mention supraventricular, you cannot point to a specific. It's all that is telling us is that it's telling us it's above the ventricle. It's not specific. So it could come from the cells in the atria, it could come from the sinoatrial node, it could come from the AV node, above. So the moment you say supraventricular, it's above. And the rhythm is now talking about the rate. Can you hold on for me? Hello.
Hello, Doc.
Hello. Uh-huh. Steve,
Hello, Doc.
I beg you, do this for me. I don't like to be seen TORI, those things. So please, if you are not seeing any full names, delete those names from it. You are now the host.
Noted, Doc. Yes, please.
So I don't, if it's not a full name, delete it. I've told you this. Then you'll be checking, they'll be using. So do that for me.
Yes, sir.
Because we are using a dubious means to join. Dubious means to join. Some are recording and they're giving it out. Some are joining without our consent. So take all those things, let them come in with their name. Okay. So paroxysmal supraventricular. So it's telling you that the problem, the source of this tachycardia is coming from above the ventricle, supraventricular, above the ventricle. That is the source. Above the ventricles, that is the source. And now the rate comes here. It's tachycardia. It's giving the rate. It means
That's
it's
what I'm saying.
okay. And it's tachycardia. When you say tachycardia, It means it's fast. The rhythm is fast. The problem is coming from above the ventricle. And where the problem is, the impulse discharging from that area is coming like a burst. It's coming like a burst. So I'm doing this for you to appreciate that when you mention any type of arrhythmia, when you say it, you shouldn't be scared. When you break it down, you appreciate it. Okay, somebody should do this for me. So we have paroxysmal ventricular fibrillation. I want somebody to explain this to me. Who can do this for me?
Attakorah. Proximal ventricular fibrillation is when you have impulses from multiple cocci located on the ventricles that are released in heavy magnitudes in a burst.
So the fibrillation is what?
Impulses from multiple cocci.
Giving you what?
A fast and a chaotic rhythm.
So we have impulses from multiple cocci, giving you a chaotic rhythm, a fast and a chaotic rhythm. So this is what? This is what?
A ventricular.
So the ventricle. This is the ventricle. So it means that the fibrillation, the source of the fibrillation is coming from where? It's coming from the ventricle. And where we are having these multiple discharge of impulses, the impulses are coming from those areas as a burst. Please, is it clear? Is it clear?
Yes, Doc.
Okay, so the last thing, I intentionally put that as last, such that I can go further. The last thing is block. So you could also have a block.
Doc, please question.
Okay.
No, please. I am with respect to the what qualifies an arrhythmia to be tachycardic or maybe a fibrillation or a flutter. Please,
Mm-hmm.
Is it that the tachycardia comes from the correct notes, but they are firing in rapid succession, or there could be cancer classified as tachycardia?
When you say tachycardia, what does it mean? When you say tachycardia, what does it mean? I'm asking you a question.
So please, tachycardia is rapid heartbeat.
So the rhythm is what? The rhythm is what?
The rhythm is fast.
So the moment you have fast rhythm, and for fast rhythm, we classify it as above what? 100. So when you are above 100, we term it as what? As tachycardia. Do you get it?
Yes, please.
So when these rhythm is as a result of just a focus. This rhythm, which the first rhythm is just coming from a point. Then you'll be talking about flutter. When these first rhythm, which is tachycardia, is coming from a different multiple focal or foci, then we term it as what? Fibrillation. Is it clear?
Okay, well, yes, please.
So for flutter and for fibrillation, they are all what? Fast rhythm. But because fibrillation is coming from different foci or multiple foci, it's the rhythm will be chaotic. But the flutter is regular. Flutter, regular. To give you a regular rhythm. Okay, so block. When you talk about block in arrhythmia, block in arrhythmia. When you say block, two things happen. Two things happen. When you say block, two things happen. When you say block in arrhythmia, I understand the basis. Arrhythmia is difficult. But when you understand it, it becomes a bit easier. It is difficult. A lot of pharmacists, about 99% of them, don't like arrhythmia because basis is difficult. Arrhythmia is difficult. So get these bases. When you get different books, you'll be saying different things. At the end of the day, when you understand the basis, you appreciate what they are saying. So it's difficult. When you talk about block, two things. Block is either a delay or absence of conduction through the AV node. A block, two things. A block is either a delayed in. So you have this. You have your AV node. AV node. You have AV node. A block is absence or a delay of transmission via this. This is the AV node. So when you have absence of impulses or a delayed, so the impulses has to delay for say 0.1 seconds in the AV node, and it's delayed by 0.2. And this could be termed, because there's a further delay, this could be termed as what? As a block. You could have a situation whereby impulses will get into the AV node, but none of these impulses will get into here, will get into the ventricle. This is also a block. This is absence. This is also a block. So when you have delay of impulses, some of the impulses, when you get to the AV node, they will delay. By the end of the day, all these impulses will get into the ventricles. They are delayed in going through the AV node. So when this happens, we term it as what? It's a block. So block in arrhythmia means that when there's a delay in or absence of conduction through the AV node, when you have this, we term it as what? It's a block. Any question here? For block in arrhythmia, note this, for block in arrhythmia, you could have first degree block. It's in your being. First degree block. We have second degree block. And we have third degree block. Even under the second degree block, we have sub, but I'll not go into that. For a level, you should know first, second, and third degree block. We have this block. First degree block, second degree block. Last 2 years, I set questions on this. BNF will tell you that who can do this explanation? We haven't completed the block, but it's in your BNF. BNF will tell you that beta blockers are contraindicated in the second and third degree block, but it should be used cautiously in first degree block. Who can explain it to me? Why is it so? It's in your BNF. Who can do that for me? BNF says that beta blockers are contraindicated in second and third degree block. It should be used cautiously. First degree block. Can you do it for me? Yes or no?
Doc, I will try.
Mm-hmm.
Let them try.
Okay, Doc, so the reason why it's contraindicated in the second and third degree blocks is because mostly in the first degree block, there's just a further delayance from the 0.2 seconds to somewhere 0.22. But in the third and the second degree, there's more or less like no sending of impulses to the ventricles at all. So giving beta blockers will further shut the heart down. But in the first degree block, there's a further delayance to 0.22 seconds. So there, you can use it cautiously.
Okay. Okay, so you are right. So what is first degree block? What is second degree block? And what is third degree block? When you know this is what I like you to know, understand. You know what a lot of people are doing? I had a student who came from, I won't mention that country's name, came and all that he was doing is to he was telling me that me, if I get the past questions, I'll pass. So friends give the past questions to. I'm not saying past questions are not good. What I want you to know is that when you understand the topic, this is what I've been pushing for. When you understand the topic and you apply it, after understanding, you pick past question and try your hands on. Perfect. Don't you the way you try to go without understanding the topic. Some of you are doing that. Solving past questions. Be lucky. Maybe the past questions will come. My advice is that get the understanding, such that when I had a question last 2 years, I had a question on second degree block, a case. So if you don't understand it, I'm not saying this year, I'm not saying I said questions on that. I'm saying 2 years ago, I said questions on second degree block. So understand it, please understand it. Okay, so when you talk about first degree block, now you have impulses from sinoatrial node. This is the sinoatrial node. This is your AV node. When these impulses from sinoatrial node get to the AV node, we say that in the normal heart rhythm or the activity of the heart, there's a delay here. And this delay would ensure that there's a total contraction. There's total atrial contraction and there's total ventricular relaxation. And so impulses, when they get to the AV node, there will be a delay. But in first degree block, listen, in first degree block, as Steve said, there will be a further delay by 0.22 seconds. There's a further delay if initially it's 0.1 and it's moving to 0.2 seconds. If it's 0.2 and it's moving to 0.22 seconds, what I'm saying is that there's a delay, a further delay. But at the end of the day, all the impulses will get into the ventricles. So there's just a delay. You send somebody to go and buy food for you. You're expecting that the person will use about 5 minutes, looking at where they serve the food, 5 minutes. The person goes, you send the person goes, and the person came back in 20 minutes time. You're expecting the delay to be 5 minutes. Now, there's a further delay by this. Now it's 20 minutes. So 15 minutes, there's a further delay at 15 minutes. But at the end of the day, the guy that you sent has come. Come with your food. So there's just a delay and delay. So this is first degree block. For first degree block, there's a delay, a further delay that AV node. But at the end of the day, all the impulses will get into the ventricles to cause contraction. Second degree block. Second degree block. So for second degree block, what happens? Second degree block, what happens is that impulses from the atrial node, when they get into the AV node, listen good. When they get into the AV node, if you assuming you have 10 impulses, the 10 impulses are coming from the sinoatrial node. When they get into the AV node, not all the 10 will get into the ventricles. Some of the impulses will be taken up by the AV node. That is the second degree block. For the second degree block, not all impulses coming from the sinoatrial node will get into the ventricles to cause contraction. First degree block, we have impulses delaying. There's a further delay of impulses within the AV node. At the end of the day, all the impulses will get into the ventricles. Second degree block. So first degree, if you have 10 impulses coming from side intranode, there will be just a delay. At the end of the day, all the 10 will get into the ventricles. Second degree block, 10 is coming. At the end of the day, 5 will get into the ventricle. 5 will get into the ventricle. It means that some of the impulses has been taken up by the AV node. That is second degree block. The third degree block. So you send somebody to go and buy you your kogari, buy you food. You're expecting a change of 10 cedis. You're expecting a change of 10. The person comes back with a change of what? 5. It means that he has taken what? He has taken 5. And first, now we turn those things over to boat. We say what to boat. I don't know whether we still use that word. So he has taken some. So that is if this scenario is happening. You send somebody, you expect him. You give 10 cedis, 20 cedis. You said you should buy the food up to 10 cedis. So you're expecting 10 cedis. The patient came. The person came and said that he gave you what? 5 cedis. It means he has taken 5 cedis. So when these happens, we term this as second degree block, where part of the impulse is coming from the signature node. Some will be taken by the AV node. So not all will get into the ventricles. The last is the third degree block. The third degree block is that none of these impulses from the sinoatrial node will get into the ventricle. It means all these impulses will be taken up by the AV node. All these impulses will be taken up by the AV node. Is it clear about the blocking? Any question about the blocking?
Please, can you repeat the third degree block?
Steve,
Hello, Doc.
can you explain the third block to them for me?
Yes, please. So with the third degree block, though impulses are sent all right from the SA node to the AV node, but ideally we're expecting the impulses to move from the AV node to the ventricles. But here, all the impulses are taken up by the AV node, so none will be sent to the ventricles.
So we call it, another name is what?
Complete block.
Another name is complete block.
Thank you.
You understand? This is the basis, and an application is coming. So if we had a second degree block patient at the Confanoche, the doctors were giving beta blockers, second degree, and this is where the application is. How do you explain this? Second degree and beta blockers. BNF say that it's contraindicated. Contraindication in second degree. Who can do this explanation for me? Why is it a contraindication? beta blocker, and second degree. Now, third degree, there, we don't go there because third degree, none of these impulses will get into where? Will get into the ventricles. We are talking about complete heart block. And if I ask you a question, how will a patient with a complete heart block live? How would they live? Patient with complete heart block, how would they live?
So, Doc, for such patients, we can maybe replace their pacemakers or something so that they can get something to start the automaticity.
So they have to replace the AV node. Huh? And my point is that at times it will take about a month before they will do the operation they will do the replacement. But the patient will live up to that time.
Hello.
So how will the patient live? Steve, do you get it?
Yes, please.
Doc,
Yes.
Doc, I was thinking the other points of the conduction, so the bundle of His and the Purkinje fibers, so they can also generate some level of impulse when they are not receiving it from the AV and the this can help support the patient's cardiac activity until the patient receives a replacement.
Okay. So let me tell you this. Such patient with complete heart block, such patients will live. We call something escape rhythm. Note this. We call something escape rhythm. The patient will live by escape. Who can explain this to me? And what you call escape rhythm mechanism. Escape rhythm. The patient, you put a patient in a prison. Now, you put a patient in a prison. The patient will devise a means to escape from the prison. There will be 20 in the prison. But one would try and escape from the prison. Now, the impulses will be in AV node. But we are saying that these patients, complete heart block patients, will live via escape rhythm because the system has to survive. And therefore, this escape rhythm, now the impulses will be in a prison. The AV node would put all these impulses in a prison. Therefore, because the system has to survive, some of these impulses will escape. You'll be there. And one would escape just to cause the contraction. This is the way God has made it. So we say that these patients will live by escape rhythm. When impulses, what kills the arrhythmia patient easily is when impulses are generating from the ventricles. When they are generating from the ventricles, it's killed them easily because it will be difficult to trace it, to trace the path from the Purkinje fibers up to the top. But it's easier from the top tracing to the down. So they will leave by a method called escape rhythm, where you'll be there and one impulse is to escape from the prison within the AV node and come and cause the contraction just to sustain the system. So the replacement is done for the patient. So I am talking about beta blockers. Beta blocker, why is it that beta blocker is contraindicated in the second degree block?
Doc. So when you were explaining the second degree block, you talk about if 10 is coming, 5 leaving or exiting the AV node. So when we use a beta blocker, these beta blockers will even further lower the number of the impulses that are exiting from the AV node. So if it was 5, that would have normally exited, maybe 1 or 2. And this will further worsen your patient's outcome. So that's why it's usually contraindicated, because it further slows down the conduction through the AV node.
Okay, you are right. You are right. I'll be doing something with you. So I will touch on it later. You are right. Let me do a further explanation, adding something to it. You are right. Beta blocker or beta blockers shouldn't be used in second and third degree block. It's contraindicated. It's in your being. Second and third degree block. It's in your being. And this is the explanation. I'm adding some to what Kevin said to get a basis. If you don't even get a question from arrhythmia and you understand arrhythmia, it's the best. But no, we are treating all these way, because you may not know where the question will come from. Last year I do a full arrhythmia, atrial fibrillation. So we need to learn, but what I want is the understanding. You understand. So listen, for the second degree block, listen. For sinoatrial node to release impulses. Listen now. For sinoatrial node to release impulses, it should be under the influence of the sympathetic arm of the autonomic nervous system. For sinoatrial node to release impulses, there should be stimulation, sympathetic stimulation. That is why when a patient, something happens to a patient, like something happens, then sympathetic stimulation will be up. That sympathetic stimulation is up, then the heart, because there's up, we have up the sympathetic activity, it would cause stimulation to the sinoatrial node to release more impulses, to cause more contraction. So for impulses to be released, you need sympathetic stimulation of sinoatrial node. And second degree block. For second degree block, some of these impulses, when they get into the AV node, some of these impulses will be taken. So assuming you have 4 coming, 2 will be taken and 2 will get into the ventricles. Now we are using beta blocker. And what beta blocker does is that beta blocker will block the beta receptors and the SA node. So beta blocker will inhibit the sympathetic effect And therefore, inhibiting the sympathetic effect on the sinoatrial node will reduce impulses coming from the sinoatrial node. And therefore, if there's reduction now, if there's beta blocker inhibiting sympathetic effect on sinoatrial node, some of these, there will be reduction of impulses from the sinoatrial node. And when these impulses also get here, there will be a further reduction. So it's contraindicated. Why? Because beta blocker would block the effect of sympathetic activity on the sinoatrial node. When the activity is blocked, impulses that will be released from the sinoatrial node will be reduced. And when these happen, there's reduction of impulses from sinoatrial node. And when they get into the AV node, there will be a further reduction. So assuming it's 10 and 5 is taken, 10 coming, because of the beta blocker, there will be further reduction. So it will not be 10. It will be, say, 6. Then when you get here, 5 will be taken, then 1. It means that virtually you are reducing the impulses getting into the ventricles to cause fibrillation, to cause contraction. So beta blockers are contraindicated in first second and third degree block. For third degree block, there's nothing here, nothing coming. And if you are reducing it, nothing will get into the ventricles. And if you are further reducing it, then even the escape rhythm will be affected. So note second and third degree block, beta blockers shouldn't be used. Second and third degree block, beta blockers shouldn't be used. A beta blocker should be used cautiously in first degree. In that, in first degree, there will be just a delay here. So if you use beta blocker, it's going to reduce impulses coming from the sinoatrial node. So if we say 10 and 5, say it's causing a reduction. Beta blocker is causing reduction and release of impulses from the sinoatrial node to be, say, 6. When these 6 gets to the AV node, there will be a further delay. But at the end of the day, all the impulses will get into the ventricles. And therefore, we say that we should use cautiously. Cautiously. There's a caution in using beta blocker in first degree block. A second degree and third degree block. That's contraindication. Is it clear? Should I move on? Can you hear me?
Yes.
I should move on. Should I move on? Yes or no?
Yes,
please. Please kindly move on. Thank you.
Okay. Okay, so let's talk about the diagnosis. How do you diagnose arrhythmia? How do you diagnose arrhythmia? How do you diagnose arrhythmia? Who can tell me? Oh, who can tell me how do you diagnose arrhythmia?
Abnormal ECG rhythm. Can we use that?
So how do you diagnose arrhythmia? How do you diagnose arrhythmia? Who can tell me? Diagnosis of arrhythmia. Who can tell me?
It can be diagnosed using the car assessment.
Using what?
It can be diagnosed using clinical assessment where you take clinical assessment where you take history, like history taking, and you can also diagnose it using the ECG.
So you assess the patient and use ECG. This is ECG is used. ECG is used to confirm. ECG is used. It's the main tool for diagnosis of arrhythmia. ECG is the main tool for diagnosis of arrhythmia. So let's learn something small about this ECG. Learn something small about this ECG. The pattern will be like this. If I'm not doing it well, forgive me. So this is the unit, and this unit will be replicating itself. This unit will be replicating itself, and it will be a meaning of something. That is the pattern. So this is the pattern. So the unit of the pattern, we have what is called P here. We have what you call Q, R, X, Q, R, X. We have the T here. This is the unit. There will be continuation of this P. Other waves, P will come again, QRS. So depending upon what is happening, then they will read the pattern. They will tell you that because of P wave. Now, this is P wave. P wave. If P wave is flattened, because you know the meaning of P wave, and if the P wave is flattened, you can say this is what is happening. So let me say this. What is P wave? What is P wave? What is the meaning of the wave? P.
Hello, Dr. Attakorah, please. P wave means atrial depolarization.
So atrial. So what does it mean when I say atrial depolarization?
The contraction of the atrium.
So atrial depolarization, that is the contraction of the atrium. And therefore, if I see P wave flatten like this, what comes into my mind? What comes into your mind? The atrium is not contracting. So in fibrillation, the atria can appear as this. One is atrial, or the atria is fibrillating. The P wave could appear as if it's not contracting because there's abnormal rhythm. This rhythm is coming from here, this rhythm is coming from here. It will appear abnormal, and it will appear as if the atria is not contracting. So P wave is what? It's atrial contraction. KRS complex means what?
Please, it means ventricular depolarization.
Ventricular depolarization, meaning
The contraction of the ventricle.
the T wave, meaning what?
Ventricular repolarization.
So ventricular repolarization, meaning
The ventricle is resting, relaxing.
so relaxation of the ventricles. Okay. What is now P? This is P, and this is R. What is PR? What is PR? What is the meaning of the PR?
Look, I think the impulse that travels to the AV node from the senoidal node.
Impulse that travel.
That the impulse that travel to the AV node from the it is the time that is taken to is the time in which the impulse traveled through the AV node from the senoidal node.
So this is where the travel will occur. This is where the AV node is. This is the junction of the AV node from the ground, from the pattern. So the P wave, how do you link the P wave to blocking? To the block? Is there a linkage? Is there a linkage between the block and the PR?
Yes, please.
What is the linkage?
So since we established that a block is a delay or absence of conduction through the AV node, if there's a block, it means that there will be prolongation of the PR interval. And as such, it can help us, see where the block actually is, if it's second degree or the likes.
So if I want to use the PR to define the first degree block, what to be? How will I use it?
Okay, so first of all, we have to know the distance, which is the normal delay, and which is 0.2. Then we measure on the ECG sheet. So if there's a first degree block, it means that we're expecting a 0.02 seconds increment. So if the PR delays by a further 0.02, it will sort of prolong. And then from that, you see on the ECG sheet that, here there is a first degree block.
So the PR is the time it will take, it's the time interval to take for impulses to travel from the sinoatrial node via the AV node to the ventricles. So that is the PR. And because it's talking about time impulses to travel through the AV node, the PR could be used to describe the block. So it means that for first degree block, and the PR, there will be further prolongation of what? The PR. Further prolongation of the PR. Certain groups, Kuma and Clark, will be using PR. Kuma and Clark will not be doing the explanation simple like what I'm doing. Kuma and Clark go straight to the point. So if you don't appreciate, it will be difficult to understand. So normally, when you are learning a topic and you don't understand, don't start the Kuma and Clark. When you understand the topic and you can read about Kuma and Clark, you appreciate it more. Okay. I'm saying this, but 99% of you are not using even Kuma and Clark. You don't even know Kuma and Clark. Okay, so PR, what is ST? What is ST elevation? What is ST elevation? Or ST segment? What is ST segment? What does it refer to? ST segment.
The ST, when elevated, can help us know if there's any form of occlusion. So it helps in the diagnosis of ACS, such as the NSTEMI and endostemy.
So please don't use the word any form of occlusion. Don't generalize it like that. It should be specific. And that specific will point to what?
The persistent occlusion.
That specific will point to what? Will point to. You should be fast. You point to.
A thrombus.
There's occlusion. And for you to link the occlusion to ST, the occlusion should be in where? You just say occlusion. You have generalized it. Seven, do you get what I'm saying?
Yes, sir.
You don't get it.
So myocardial occlusion?
It should be in the coronary artery.
In the coronary artery. Do you get it?
Yes, please.
Don't just you just said occlusion, and when you just say occlusion within the veins in the brain will not give you the ST. You get it?
Yes, sir.
So occlusion, ST, segment, signifies. If it's normal, it means you don't have any occlusion within the coronary vessel. If there's an occlusion, there will be ST elevation segment, and that will point to occlusion in the coronary vessels. Now we have QT. QT. What is QT? Interval. What is QT? We have the Q here. We have the T here. So what is QT?
And please, it is the time between the contraction and relaxation of the ventricle.
So we say there's a danger when you prolong the QT. Why is it that there's a danger when you prolong the QT?
Attakorah can cause stasis, blood stasis.
How will it cause blood stasis?
Blood blood will be collected in the or will stay in the ventricles.
I'm just asking, how will it cause stasis? You prolong the QT, how will it cause the stasis? Oh, you are right. You said to cause stasis. How will it cause stasis?
Mm. Dr. Attakorah, so since there's a prolonged relaxation time, the blood will stay in the ventricles for a very long time. So
Can you start again?
so I'm saying that QT is the time, since QT is the time taken for the ventricles to contract and relax. If there's a prolonged QT time, there will be a collection of blood in the ventricles for a very long time or for longer. So that prolonged time will cause the blood um to clot. I don't know how to put it.
Anybody? Anybody? Hmm. So we are talking about QT interval. And you are telling me it's time between ventricular contraction and ventricular relaxation. So ventricular contraction and ventricular relaxation. This is QT interval. So what could happen is that anything that will cause a change in ventricular contraction and ventricular relaxation or both will cause QT prolongation. If it so happens that you prolong the contraction, if the contraction should take 2 seconds and the relaxation should also take 2 seconds, then something happens. Now the relaxation, the contraction take 3 seconds. The relaxation take 2 seconds. What is happening to this? There's QT prolongation. If we have relaxation, contraction taking 3 seconds, and relaxation taking also 3, there's still QT prolongation. So the problem is that if we prolong the relaxation, the danger is stasis. There's stasis. If you prolong, there's a stasis. And when you have stasis, what is the danger of stasis? The system becomes hypercoagulable, meaning that there could be clots. So the system becomes hypercoagulable as a result of prolonging the relaxation. As a result of prolonging the relaxation, there will be clots. And the danger of these clots is that these clots could be thrown into the system to cause stroke, to cause PE, DVT, and others. When you prolong the contraction, what could happen is that you could deplete the blood within the ventricles, such that number one danger is that when there's any dirt within the ventricles, anything within the ventricles, this could be thrown away. The second danger is that you could delay, so there will be perfusion, poor perfusion to the other vital organs, because now instead of contracting for 2 minutes, you are contracting for say 4 minutes. So the ventricle has to relax to take in blood. Then you prolong the contraction. And this would cause hypoperfusion, delaying perfusing the vital organ. Therefore, prolonging the QT is deadly. Prolonging the QT, whether it's as a result of ventricular contraction, prolonging the contraction, or as a result of prolonging the relaxation, any of this is deadly. Prolonging the contraction means that you delay in perfusing the vital organs. Delaying the relaxation means that there will be stasis, and then these would also expose the system to clots or coagulation. And when these coagulation forms, contraction will push these clots into the brain or into the lungs or into the veins, DVT and co. So this is that. So QT interval is very important. So if a patient comes with a heart problem and you are giving any drug that will prolong the QT, please be careful. Patients with heart problems, don't give medication that would prolong the QT. Because if patient comes with heart failure, QT is affected. And when you are giving any medication, that will further prolong the QT. That will be deadly. What are some of the medications that will prolong the QT? Some of the medication that will prolong the QT. Some of the medication that could prolong the QT. Some of the medication that could prolong the QT. What are some of the medication?
Oh, we have the quinolines.
We have the quinolines.
Yes, please.
Mm-hmm.
For example, ciprofloxacin.
Mm-hmm. We have a lot of medication, so please.
Azithromycin.
So we have azithromycin.
Quinine.
What?
Quinine.
I hear you. We have a lot of medications. So look for those medications and put it. Look for those medications. We have a lot of medication. We have lithium. We have class A and class 3 medications. Arrhythmia medications. We have these medications. We have haloperidol. All these medications, clarithromycin, erythromycin, all these medications will prolong the QT. So please, note medications that could prolong the QT. Medication that could prolong the QT. Medications. Any question up to this point?
Yes, please, Doc.
Any questions?
Yes, sir. Please, I have a question.
Okay.
Please, on the ECG, mostly after talking about the atrial depolarization, we mostly don't talk about the atrial repolarization. So I wanted to ask, is it that the ventricular depolarization will mask it, or it doesn't occur at all?
Can you come again? I want to understand your question.
Please, we established that the P wave is the depolarization of the atria, and the QRS complex is the depolarization of the ventricles, and then the T wave would be the repolarization of the ventricles. I wanted to know if there's no atrial repolarization, because I didn't see we talk about it.
There is atrial depolarization and atrial repolarization. But let me tell you this. For the heart, you could have, when you have issues even at the atria and your ventricles are working effectively, if you don't take care, you won't see. But when we have a slight issue at the ventricles, slight issue to be seen. Do you get what I'm saying?
Yes, sir.
Slight issues about ventricles, because it does the pumping, either to here, either to the lungs, or to the general circulation. But we have atrial repolarization that is not shown on the ECG. But we have other waves. That's why I'm saying that we have K waves, we have F waves. We are not taught. But there's atrial depolarization, atrial repolarization. But the ventricles, normally the ventricles are the most important chamber. There could be problem about even contraction P wave. But if your ventricles are working effectively, then it will be difficult for you to even see that there's a problem over there. But there's a contraction and there's relaxation. The P wave should relax, such that we receive what? Blood. But because the ventricles, that's the pumping. As if our eyes are on them, and the slightest thing about the ventricles could cause a lot of. So, but there's a P wave, there's a wave. So the atrial could contract, the atrial could what? Relax. But the wave captures the contraction. It doesn't capture the relaxation. Do you get it?
Yes, sir. Thank you.
In details, if the cardiologist, it pains me that is the area, like the pattern, reading of the pattern is my issue. We are not taught how to read. I don't know whether you guys, I'm sure you are taught. Are you taught? Were you taught A and E about how to read ECG? Were you taught? Steve?
Doc, mostly they'll be interpreting and you'll be watching, but it's not really practical to us. So by the time we leave there, we forget. Yeah.
We need to. I will push that those in fifth year, those who are coming, we need to know, because it's about medication. Last, I went to US, Michigan, for this, just to observe their practice. And when I came back, my thoughts changed. The way I see the clinical. We are doing clinical and we are far from the doctors. We are far from the doctors. We think that this is for the doctor. Ours is for medication. I went there in one of their meetings. I was observing them, one of their meetings, and a lady pharmacist. What they do is that before they go to the ward, the team would meet and review all their cases. So they will review all their cases before they get to the ward. So before they get to the ward, they know what they are going to do on patient A, B, C, D. So they will discuss. A pharmacist will come in. Dietitian will come in. If it gets to nursing, a doctor will come in. So they will discuss, a thorough discussion. Then there was issue about arrhythmia. And then the pharmacist, a lady pharmacist, I was so impressed, saying that because the P wave is inverted, they were given a certain drug and said that because the P wave is inverted, they shouldn't give that medication. And I was shocked, because if you don't understand the pattern, if you don't understand the disease condition, it will be difficult to push, to point certain things out. I realized that we are far, far, far from. We are leaving these things for the doctors. I'll be pushing that we'll be taught in fifth year. Then you stop your spiritisms and go. Such that when you see the pattern, you can see that this is a traffic. And therefore, the nurses outside are being able to tell what is happening, whether it's atrial flutter, whether it's supraventricular. They will just be saying these things. So, Steve, there's atrial contraction and there's atrial relaxation. Either than that, there won't be the total function of what? Of the heart. The heart, the atria should relax, atria should. But the P wave here is linking to atrial depolarization. But I know when you are good in reading the pattern, you will know all these things. They measure the boxes and they will tell you this. They measure the height and they will tell you this. So this is what we need to do. And I will try to. I was asking some of the doctors to take us through, but I wasn't getting time. So we need to know the pattern, read the pattern, such that we can. Is it okay? Hello?
Hello, Doc. Thank you very much.
Okay, so let's do this. Let's do this. Let's do this. I want us to get. We'll be learning about types of cardiac tissues. We'll be learning about electrophysiology. Then I'll meet you tomorrow because it's one class. I can join them in the meeting and do it every day. I want to finish about 2 topics with you, or 2 or 3 topics. Then, so let me do types of cardiac tissues. Types of cardiac tissues. You need to know this. When you know this and it gets to the medications, or when you have atrial fibrillation, you would apply. Hey, that all that we are learning, when it gets to the medication, you need to apply. You see types of cardiac tissues. You need to know the types of cardiac tissues such that you would apply. When there's issue, ventricular something, sinus something, you will know where to tackle, which drugs to start, because it's sinus problem, it's AV node problem, nodal. When it's nodal, you know where to start. Okay, so types of cardiac tissues. Types of cardiac tissues. So basically, we have 2 types of cardiac tissues. 2 types, basically. We have 2 types of cardiac tissues. And it's important for you to know this. So we have first one. We have first channel tissues. First channel tissues. And 2, we have slow channel tissues. First channel tissues, and we have slow channel tissues. This is important in terms of management. You should know all this because of the management. So when you talk about fast channel tissues are areas in the heart, certain areas in the heart. And these areas in the heart, they have high density. When you say fast channel tissues, these areas have high density of fast sodium channels. These areas have high density of fast sodium channels. And because they have high density of fast sodium channels, I'll be doing electrophysiology when I finish with this. maybe probably tomorrow. I'll do this. I'm doing more explanation, that's why it's prolonging. So fast channel tissues. The cardiac tissues are the heart is basically divided into two, and arrhythmia. And we have the fast channel tissues and the slow channel tissues. The fast channel tissues contains high density of fast sodium channel. Fast sodium channels. Fast, they have fast, contains high density of fast sodium channels. Sodium channels are fast in terms of conduction. They are fast. And these areas, the areas that contains high density of fast sodium channels are, we have the atria. So these areas are the atria. We have the atria, we have the ventricles. So atrial myocytes, ventricular myocytes, we have bundle of it, and we have Purkinje's fibers. All these areas contains high density of fast sodium channels. You will not appreciate this. But in terms of management, you will appreciate. So note these things. Now, when you get to the medication, some of these medication will work well in the atrial myocytes. Some will work well in sinoatrial node or AV node. So if we have atrial fibrillation, it means that the problem is coming from atrial myocytes. And therefore, I have to look for medication that will work well in the atrial myocytes. This is how come I'm saying this is very, very important. Two types: fast channel tissue and slow channel tissue. Fast channel tissue contains sodium, high density of fast sodium channels. And the areas are the atrial myocytes, ventricular myocytes, bundle of it. And we have Purkinje's fibers or system. So these are the fast channel tissues. These are the fast channel tissues. So the slow channel tissues are those areas in the heart. And these slow channel tissues contains low density of fast sodium channels, low density of fast sodium channels, low density, fast. The fast channel tissues contains high density. The slow channel tissues contains low density of fast sodium channels. Please, high density of fast sodium channel. So the areas of fast channel tissues are the atrial, the ventricular myocytes, bundle of this. The slow channel tissues are the sinoatrial node, and what? And the AV node. Sinoatrial node and the AV node are described as slow channel tissue. Why? Because they contain less density of sodium, fast sodium channels. Fast sodium channels. Is it clear up to this point?
Yes, sir.
Hmm?
Yes, Doc.
So let's see some of the characteristics of the fast channel tissues. Fast channel tissues. Let's see the characteristics of the fast channel tissues. These fast channel tissues are what? Are the atria. Let me start from the slough such that you appreciate it more. The slough, which is S, A node, and AV node, are the slough channel tissues. And one characteristic is that they have a low density of fast sodium channels. They have a low density of, and take note of this, because sodium channels, conduction in sodium channels are fast, and they have low density. Over there, they have a low sodium channel. The density of sodium channels in there is low. It means that, listen, one of the characteristics is that there's a slow velocity conduction. So electrical conduction or impulse conduction via this SA node or AV node is not fast as compared to the atrial, as compared to the ventricle. It's not fast. That is their characteristics, one of the characteristics. Another characteristics of slow channel tissue is that they have rapid, spontaneous diastolic depolarization. Rapid, spontaneous diastolic depolarization. Rapid, spontaneous diastolic depolarization. Something spontaneous. We mean something comes spontaneously. It means that the long words, the long sentences simply means that it has a pacemaker activity. It has a pacemaker activity. There's a rapid, spontaneous. One even is a diastolic. One is that area is resting and the cycle is complete. There's a rapid, spontaneous diastolic depolarization, and that will cause release of what's more impulses. So they has a pacemaker activity. There's a slow conduction velocity. There's a slow conduction velocity. This is some of the characteristics of what? Characteristics of slow channel tissue. Let's move on to the characteristics of fast channel tissues. Based upon this, we can say that the fast channel tissues, because it contains high density of what? High density of fast channel fast sodium channels, high density. The conduction via these areas are fast. So conduction via the atrial myocyte, because that area contains fast, and you need to just, the understanding is so simple. You have millions of these myocytes, and the impulses has to travel such that it can stimulate every cell. So because conduction has to be fast, that is why it contains these sodium. sodium channel, so much sodium channel, such that when impulses get the conduction will be faster. So this channel is called fast channel tissue because it has high density of fast sodium channels. We'll be talking, when I finish with this tomorrow, I'll be talking about electrophysiology. Then I will talk about the medication. And I move on to atrial fib, and I call it a day. Call it wave 4. So because of time, but normally atrial fibrillation is the commonest that comes. Atrial flutter and those could have a lot of these. Ventricular fibrillation, this. So I would do atrial fibrillation, and that would be all for arrhythmia for now. Okay, so for fast channel tissues, they have, listen, for fast channel tissue, they have little or no spontaneous diastolic depolarization. They have little or no spontaneous diastolic depolarization. They have little or no spontaneous. For SA node, which is under slow channel tissue, they on their own spontaneously they can release what impulses. But fast channel tissues, they have a little or no spontaneous diastolic depolarization. This is simply, they have no pacemaker or little pacemaker activity. The next characteristics is that they have rapid conduction velocity. They have rapid conduction velocity. Why? Because of the high density of fast sodium channels. So tomorrow I will start with electrophysiology. I'm talking about channels. So I'll be talking about these channels and how these channels behave to cause contraction. Then I will talk about So I'll be talking about electrophysiology, about these channels. We talk about the medication. It's difficult to understand these medications. Class 1A, class 1B. Question up to this point. Any question up to this point? If you don't have any question, then we'll be meeting tomorrow.
All right, Doc. Thank you.